to Dr. Saurabh Kura. Please come on to present comparative study between phaco-capsulotomy and needle aspiration in white intumescent cataract.
Good morning to all my teachers. I'm a second year postgraduate from Bangalore. So my topic is comparative study between phaco-capsulotomy and needle aspiration technique in white intumescent cataract. So phaco-caps emulsification has become a standard technique. So no step is in contemporary cataract surgery is as important as anterior capsulorhexis. So white intumescent cataract constitute a significant volume in our practice, and surgical technique is very important. So capsulorhexis can be difficult in these eyes because of compromised red reflex and high interlenticular pressure. So hence the rhexis has an inherent tendency to run out to the periphery. So when this occurs, the appearance of a stained anterior capsule besides the white cataract mimics the blue pattern of the Argentinian flag. So it was named as Argentinian flag sign. So this may progress to complications like zonular dialysis, posterior capsular tear, and vitreous loss. So different methods have been tried to prevent the uncontrolled extension of capsular rhexis. That is needle aspiration, which is standard technique, two-stage technique, femtosecond laser assisted capsulotomy, and phaco-capsulotomy, which is a novel technique. So multiple studies demonstrate how safely to do phaco-capsulotomy, but there are only few studies which compare it with other techniques. So here we intended to conduct this study to study the efficacy and safety of phaco-capsulotomy and needle aspiration in white intumescent cataract. So our objective was to compare efficacy and safety between phaco-capsulotomy and needle aspiration in terms of intra and post-operative complication, and to compare the post-operative visual outcome between these two techniques. So 60 patients diagnosed with white intumescent cataract were selected in this prospective study. So 60 patients were divided into 30 each randomly. So group 1 was phaco-capsulotomy and 2 was needle aspiration. So phaco-capsulotomy is a novel technique where phaco tip is introduced into the anterior capsule and the liquefied cortex is removed, thereby reducing the intralenticular pressure. Whereas in needle aspiration, a 26.5 gauge needle is introduced into the anterior capsule, thereby depressurizing the nucleus and helps in controlled capsular rhexis. So statistical analysis was done by chi-square test and Fisher exact test, analyzed by SPSS version 20. And inclusion criteria was only white intumescent cataract. Exclusion criteria was cataracts with corneal opacity, glaucoma, iritis, and suspected retinal diseases. So all these individuals satisfying these criteria, after enrolling into the study, a detailed history of the patient was taken, and individuals were subjected to general physical, systemic, and thorough ocular examination. So intraoperatively, here we were observing for elevation of flap and continuation of rhexis, radial extension of the rhexis, discontinuity of rhexis, any decrease in the intralenticular pressure, in total decompression for assessing the leakage of liquid cortex, and the centration of capsular rhexis, posterior capsular rupture, and vitreous loss. Post-operatively, we look for corneal edema, iritis, raised IOP on day 1, first week, first month, 3 months, and 6 months. So intraoperatively, flap elevation was noted in all the cases in phaco-capsulotomy, whereas only in 80% cases of needle aspiration it was seen. And extension into periphery was seen in 3% of patient and 30% in needle aspiration. Centration of capsular rhexis was almost in 97%, which is more significant than 73% which was seen in needle aspiration. Decrease in intralenticular pressure was noted in 67% in phaco-capsulotomy and 40% in needle aspiration. Posterior capsular rupture was seen in 7%, whereas PC rupture was significantly seen in needle aspiration, that was 27%. Vitreous loss was not at all noted in phaco-capsulotomy, whereas in 7% cases it was noted. So post-operatively, which was not significant, corneal edema was seen in 7% in phaco-capsulotomy and 17% in needle aspiration. Iritis was noted in 3%, whereas iritis was not noted in needle aspiration. Raised IOP was seen in 3% of cases in capsulotomy and 10% in needle aspiration. So coming to the discussion, so when we compared our study with a few similar studies, flap elevation that was seen 100% was similar to 100% which was seen in a similar study. Extension to periphery was also noted in 27% and 2% in similar studies. Centration of rhexis was noted in 62% and 71% and 88% respectively. Decrease in intralenticular pressure was also seen in 88% in a similar study. Posterior capsular rupture was seen in 5%, 1.8%, and 2% in the similar studies in phaco-capsulotomy, whereas in needle aspiration, this was also significant when compared to the similar study. Corneal edema was also noted in 7% cases in our case, study, and it was similar in similar studies. So during capsular excess, there was more tendency of the edge to capsule to go into periphery in 70% cases. So centration of excess was found in 97% cases, and success rate achieved for capsular excess using phaco-capsulotomy is assumed to result from controlled aspiration and increased safety when compared to needle aspiration. Chakraborty et al. Also showed incomplete capsular access in 29% cases. A posterior capsular tear was seen in 2% cases, and conversion to manual non-capsulotomy cases were done in 2% of cases using needle aspiration. Vasavada et al. Examined in 60 eyes with senile mature cataract in which small rhexis was attempted initially. The rhexis was enlarged before intraocular lens. Yes, sir. Yes, sir. So I'll come to the conclusion. Yes, sir. I'll come to the conclusion. Yes, sir. Yes, sir. Coming to the conclusion, phaco-capsulotomy technique is a simple, controlled, and effective technique that extends the possibility of routinely achieving capsular excess and thus preventing Argentinian flag sign in white intumescent cataract than needle aspiration technique. Thank you.
Area of the capsule which is free of the zonules. Where zonules start and
5.5.
5
to 5.5.
Yes, 5 nearly, and then zonules start from there and then go on becoming dense and dense. So if your capsule goes into dense area, then it will run away.
It will run away.
And I have published a small one, bimanual rhexis. If you find it somewhere, contact lens and ophthalmology somewhere, I'm very poor in writing. But you have a bimanual means your left side you have your dialer and right side you have a needle. So that way you guide the rhexis by the left hand. So make it nick and then start guiding it. The fluid will come itself. Of course, I use the anterior chamber maintainer in all of them. So anterior chamber maintainer keep the pressure down and it won't allow you to run it away. But overall, these cases, whatever you do, it will run away somewhere, whatever you do. You cannot stop it. But what I do, suppose it becomes Argentinian flag, you make the another rhexis small one, half moon, and half moon other side. So your bag will still become intact. If you make the two small rhexis, here and here, or anywhere on this ruptured one, you can still make the bag intact. I think this is for, thank you so much.
So may I ask a question?
Just one, yeah.
Have you been in operation theater and seen how these two techniques are done?
Yes, sir. My guide was...
He was doing? Okay. So tell us how phaco-capsulotomy was done.
So phaco-capsulotomy, we basically, phaco tip is introduced into the center of the anterior capsule and the power of... Phaco-capsulotomy is introduced into the anterior capsule and power of 200 and aspiration flow rate of 28 cc per minute was maintained. And the phaco machine was placed at position 2 where I&A was done. After that, the sculptor
How the capsule was ruptured? Was ultrasound used at that time?
Sir?
During initial, how was the anterior capsule was ruptured? I mean, anterior capsule has to be initiated, no? The tear has to be initiated.
Yes, sir.
By the phaco handpiece. How was it done? How was the tear initiated?
Tear was in the center, sir, up to 80%.
So you just pierce by the phaco needle, the
Yes,
central
sir.
part?
Yes, yes.
Phaco needle is quite thick and it is not so sharp. So how can you pierce that without using ultrasound?
Not use ultrasound, sir.
So you have not probably seen the technique minutely. First, a burst of energy has to be used to, to tear off the central part of the capsule. Otherwise, if you just push it, it will not cause any tear. Right?
Yes.
And also in your complications, you have mentioned the rate of cell loss and corneal edema is more in the needle aspiration compared to this thing.
Yes.
So logically, I can't understand. How do you explain that? Because only when there is a phaco this thing, there is a chance for extra cell loss. When you are doing with a needle, at least it has to be comparable. I don't think it can be more. Is there any reason why do you think it was more in your case?
There was no reason.
And you used a 26 gauge needle. It doesn't aspirate any matter actually. You have to use at least 23 gauge or something like.
आपकी guide है यहाँ पे?
Because of
Your guide is here.
no sir.
Guide को पूछेंगे ना आपको क्या पूछे? The good beta, but your corneal edema basically depends on the how much phaco power you use, and if you it's nothing to do with the capsulotomy how you did it. With they can be done with phaco tip also. It can be done with needle also. It can be done with so many methods. But edema is dependent on your phaco time, basically. And so that is basically, everybody knows that phaco time is directly proportional to phaco edema of the cornea. Thank you.